I'm Kevin Baldwin, the Informatics Portfolio Manager at UCLA. And in selecting this panel, we made an effort to pick a group of folks that are very diverse in their experiences, but also have quite a bit of breadth and depth in the types of roles and opportunities that they have had the opportunity to be involved in over the years. So I'm very pleased that they're going to be able to share a little bit of their experiences with you today. Before I ask them to introduce yourselves, could I just get a show of hands in the room of how many clinicians we have here today? Okay, I see one. Keep your hand up. And then how many technologists, so people that have some role in technology? Okay, about half. And then how many patients? How many of you have ever been a patient in your life? Okay, perfect. Then you guys are in the right place. So we're going to be talking today on a panel topic called How do you measure patient engagement and digital utilization in a meaningful and actionable way? So I'll go ahead and ask Namgyal to start and introduce yourself, please.
Okay. Good afternoon, everyone. My name is Namgyal Kyulo. I am a physician I was a physician. I used to practice in India before I came here. 20 years back, that was, and then now, last 15 years, I was working in the patient experience domain at UCLA Health, and then last 4 months, I'm with the City of Hope Patient Experience Director there.
Hi, my name is David Foster. I'm with Healthwise. I'm a Senior Director on the technology team, and I work on using patient data to show that patient engagement is effective at involving and informing people, and then also improving quality in healthcare. And I'm very fortunate to have been at Healthwise for 15 years, working on our nonprofit mission to help people make better health decisions. And I've been very fortunate to work with many different health services researchers, and it's nice to see colleagues from the health IT industry here in Southern California that I've worked with on getting data out of Epic and other things to show the value of patient engagement.
Hi, my name is Lynn. I'm the Medical Director of Telehealth at UCLA. I'm also the Chief Quality Officer of General Surgery. I'm a colorectal surgeon, and I'm very much interested in connected health, as well as remote patient monitoring to improve outcomes.
Good afternoon, I'm Diane Olson. I'm a Director of Revenue Cycle Projects at the Martin Luther King Hospital and the medical group. While I'm there right now, I've actually worked around the country. I'm an independent consultant, so some of the challenges we have at the Martin Luther King Hospital are different than other experiences I've had, so I'll be able to talk about both sides of that table. So.
Fantastic, thank you. So we've talked about a lot of topics today, ranging from remote patient monitoring. We've briefly touched on telehealth. We've talked a lot about data, and we've also talked a lot about how to manage data within the four walls of a healthcare system. To open this particular panel, I wanted to start with data. So one of the, I think, opening principles in any data management textbook is the DIKW pyramid. If you guys are familiar with that, it starts at the most basic level. It starts with data, then you want to convert that data into information, ultimately knowledge, and then the holy grail is wisdom, that you have data that's truly actionable, that you can derive insights from. So my first question, I'd love to hear from you guys if you have any examples or experiences that you could share about successes you've had with data, where you found data that's very useful either for you as a healthcare professional, or that you think could also apply on the patient side, that patients would find valuable.
Well, I can go on that. Since I work in the patient experience world, I could talk about the patient experience data. So we collect a patient feedback from their experience through hospitalizations, through the care they get at EDs or the ambulatory surgeries or outpatient clinic. We do that through a survey, and we also get it from the social media information. We collect that. We also get it from the complaint and grievances. And then we do a lot of rounding. Leadership goes to the patients bed into the units and collect the feedback from them. We call all this a patient voice. This is information that we collected from different patients from the different avenues. The main reason why we collect that information is to try to understand what their needs are, so that once we understand their needs, we could incorporate their needs into our practice and change our practice and the process. And one of the examples that I could give you is that a lot of the patients are complaining about a discharge process. And there's a question in the HCAHPS. I don't know if you know about the HCAHPS survey that we sent out to all the inpatient hospitals patients. One of the questions is about the discharge, and we scored very low in the discharge, and we tried to find out in the comment what are the reasons that we are scoring so low in the discharge questions. And we used the artificial intelligence with the outside vendor to process all the comments into different themes, try to understand what are the themes and the sub-themes. In the discharge domain, we found that the number one themes, actionable themes that we found was delay in the discharge. A lot of the patients are telling us that we are supposed to be, I'm supposed to be discharged at 11 o'clock, but I am now going home at 4 p.m. So delay in the discharge was number one thing. So number two is a rush discharge. Number three is the discharge information. So those are the themes that we found it very useful and actionable to change our practice and to make it easier for the next patient.
That's a great example. Patient experience surveying, something that we've also looked at. We don't actually collect the surveys, but our clients do. And we were able to take the HCAHPS data out of Press Ganey and compare that to the rate that patient education was being distributed at the various departments. And the tricky thing with that is that we had to organize the data in the same way that Press Ganey did. So, whatever metadata or grouping that you have with your HCAHPS survey data, we had to do the same type of grouping at the department level for the rate that patient education was distributed to patients who are seen in those locations. And then you can start to see a little bit of a trend. I won't quite say it's correlation. We're seeing an interesting signal that there are questions on that survey about, were your medications explained to you? Did the nurse explain? Did the doctor explain? And when we believe, the thesis we believe is that when patient education is distributed at discharge, that people will rate highly on those questions, saying that things were explained to them. But there's no way we would really be able to do this unless we could organize the data to compare those two data sets.
I think something that occurred to us is, as a colorectal surgeon, I would discharge my patients home with some paperwork and expect that, they did understand it. And they were reading it, but things were happening where patients were coming in. We found that a lot of them who were coming in had preventable readmissions. They were coming in and staying for less than a day or just a couple of days. These were things that, had we noticed the issue sooner, we could have directed them to the clinic and prevented an avoidable readmission. So what we've been using for some of our patients is this homegrown remote monitoring system. And we've been able to collect some information based on that in terms of, are the patients using it? Do we feel like it's actually reducing readmissions? What has the patient experience been? And it's actually been quite an amazing way for us to really have a good understanding of what happens to patients in this time period, which is usually like this black box where we just don't know unless there's a problem and they come back to the emergency room or to another emergency room. And so, what's been very interesting is not just the preventing the readmissions, but also seeing how the patients have become more active participants in their care. And so, I just remember this one patient wrote in his survey, I wasn't planning to get up and walk today, but knowing that the daily survey asks me about, walking made me actually get up and walk. So I think, this is data, information that really we're using in the colorectal surgery service and now other service lines to really help us change the way that we practice and care for patients. And, you know, I think it's an evolving process.
So I'm going to talk about the Martin Luther King Community Hospital, which just reopened in a brand new facility 5 years ago. My example would be, when I think of engagement, I think of a patient who really is collaborating in their care with the care team. And when we opened the hospital, we opened the emergency room expecting to see about 150 patients a day, and like that, we were seeing 200. Now we're seeing 300 and sometimes 400 patients a day. So from that, clearly, we have a population of patients that, first of all, it's hard for them to get care. There's not a lot of access in that area anyway. And we opened up a medical group. And it's also kind of funny to watch that now we've opened up some access to the patients, and we still have a over 50% fail rate of these patients. So, you know, we're working with, I was talking to my colleagues, and, you know, we're working with that. We're used to, you know, we grew up with role models that you go to the doctor, you go to the dentist. We're working with a population of people who didn't grow up like that. So we're out there doing outreach programs to be able to engage patients and really help them with their health. So.
Great. Thank you very much. So one step or one piece of the puzzle is, you know, collecting the data and analyzing the data. The next piece is acting upon it and creating change. And we've touched on this in a few of the other panels today. But in looking at patient adoption, or there's something in the literature known as the technology adoption curve that looks kind of like a bell curve. What are you seeing? Are you seeing people that you're reaching out to with tracking these metrics and maybe creating some interventions at the local level? Are you seeing adoption? Are you seeing patient outcomes or engagement by the different metrics we've just discussed improving?
I could go on that. So I think it depends on the health system. When I was working at UCLA like 4 months back, the email records of the patient that we have in the system is like 70 to 80%. So that makes a difference, because if we wanted to have the patient engage via my health chart, you need to have their email address with us first, and then have them open the account, and then have them educate the patient about how to use that My Chart to digitally engage the patient. And with the City of Hope, it's a little different. The email address rate is different than the Epic adoption. It's like they have adopted 2 years back only, and we are struggling to make full use of the My Health Chart to get the patient engaged. So that's a digital engagement. And also, a couple of weeks back, I was at Orlando attending Press Ganey conference. I'm sure many of you heard about the Press Ganey. So they have a great conference. One of the presenters from Cleveland Clinic, they have mentioned that the Cleveland Clinic is a kind of it's the top tier hospitals in the nation. We all know that. But they have also a challenge. They have like a 32 different patient app. So it's kind of confusing to themselves also. Their goal is to make sure that they have only one app for the patients to engage. And with that app, they should be able to communicate to the physicians, to make appointment, to change appointment, to fill their prescriptions, and if they get lost, to ask to chat to the patient, to the manager about how to get to the clinics, to find the parking places. So those are the ways of engaging patients digitally. That's what I'm thinking.
I was able to analyze data from almost 100 different Epic implementations with Healthwise, looking at all these different logs of patients, going in and looking at their diagnosis, their treatments, their labs, and then when they're in MyChart, in that Epic patient-facing portal, they can click on a link to learn more about those things in their record. I mean, we're releasing all this data to people. We ought to help people understand what's in their record so they can do something with it. And what was really surprising to me was how lab information and people wanting to understand what's in their labs, that traffic dwarfed everything else by far. People want to understand what do their labs mean. And so next what we want to start looking at is when people are able to look at information that might help them understand their lab results and see whether or not they're in the normal range, do they make fewer unnecessary phone calls to find out what's going on? You know, an earlier panel had talked about, you know, release the data. It's a non-issue. It's the person's data. I concur with that. I believe that patients need to have access to this, but I know that there's a lot of worry and concern, as stated in the earlier panel, about releasing that information and causing burden on a very busy care team. So if information helps people understand what's in their labs, then they may call less and follow up with appropriate appointments. So that's the thing that we would like to work on next, is to see, can care teams promote the use of the portal so that people can understand what's in their record and then focus their scarce time on really meaningful things that can really help them with their quality of experience.
In addition to improving the patient experience, in terms of, so as we've worked on the remote monitoring system, trying to be sure that the patients don't have too many excessive questions that are asked. You know, what is the right number of questions to be asking patients for that particular question? Is there some way that we can also then improve the provider experience so that there aren't a lot of false alerts and concerns that they need to address? And in similar fashion, does that then help to improve the overall experience of all the participants? We've been thinking a lot about that, and I mean, I think has been mentioned in the previous panels, looking at the data, analyzing that, and then using AI to really potentially help us to alert the providers. You know, we're not set up. A lot of the health systems are at UCLA, a lot of the service lines, we're not really set up to have a person answer or calling patients every day after, let's say, a hospitalization or after an operation. So having some method of really making it an efficient process for the providers is important. I'll also mention that what I found is that anecdotally, just the patients who are being monitored compared to the patients who aren't, they seem to be much less anxious about what's happening at home. I feel like they have a very good understanding of you know, what the warning signs are, and they feel great when I happen to call them to give them their results about something. They're very happy to receive the call, and then they're happy to come off the phone call. Patients who don't have this remote monitoring tend to want to ask me a lot of questions about, you know, whether or not they're doing well. And so I think it's such a beneficial thing for the patients from what I've seen.
Yeah, from a portal perspective, we don't have a great adoption of the patient portal at this point, but interestingly, the indigent population might not have a secure home or whatever, but they all have a phone, and sometimes they change their phone numbers. So we actually try to use that type of media to connect with the patients, really. So.
Thank you. And you actually brought up a few points that also I think I can share a couple interesting data points from UCLA for as well. One, Anne, you mentioned there's, I think an opportunity to influence or impact provider or, positively impact provider workflows and, them giving care to patients. One statistic that you guys, that I think will baffle you is, has to do with clinical decision support. So can anyone guess what the average national override percent is for an average alert that a provider sees? Not all at once? Any? 75%? Anyone want to take over under? 85? It's about 90 to 95% override rate. So that means the vast majority of alerts that providers are seeing, they're bypassing. And to put that into perspective, for every 100 orders the average physician places, 50 alerts are fired. So that is something that we talk a lot about in our medical informatics community, is what alerts are truly needed, and if they're needed, when do you fire them, who needs to see them, how often, et cetera, et cetera. I think the same types of questions will apply to patients if and when we get there, when we're sending them messages or patient education or other types of media or healthcare information that we hope they digest. I think the secret will be in that putting and finding out the right volume, number, timing of that information that we're sending to them. The other piece of data that you all reminded me of is when we went live with our EHR at UCLA back in 2012, our IT department was largely just serving our internal staff and faculty, which was about 20,000 physicians, nurses, administrators, et cetera. When we turned on the EHR, we had a new paradigm with the patient portal that you all touched on. And we have this really interesting graph where our volume or number of staff and faculty has pretty much stayed flat, between 20 and 21, 22,000 over the last 6 or 7 years. But the number of patients accessing the patient portal went from 0, and it's a little north of 500,000 now, probably close to 550,000 patients. So it took us a couple of years to realize, but we, as an IT department, we realized we're no longer just serving those 20,000 physicians and nurses and making sure they're able to do their job, but now we're giving tools and technologies to these 500,000 plus patients. And there's other health systems that have much fewer and many more patients than we do relative to their patient volume. So very, very interesting statistics. Next, I wanted to quickly talk about adoption for patient portals. I think has not taken off as much as people would have hoped. When people earlier mentioned financial apps and the banking industry in particular, I would guess that the majority of you have some financial app on your phone, and you probably fairly regularly check your accounts or transfer money or do direct deposits or something of that nature. What do you guys think is really holding us back, and why aren't people innovating more in that space and using the patient portal and remote patient monitoring as ways to really, really engage patients in a way we haven't seen to date?
We worked with a group that designed benefits so that the patient was actually incented to participate in the portal. And the clinicians also could see whether or not their patients were participating in the portal. And afterwards, when this plan/provider surveyed the patients, they said, almost 9 out of 10 times they said, they were actually more incented by knowing that their provider was looking at whether or not they were engaged with the material, or I guess in your case, maybe paying attention to their monitoring, than the cash benefit or the premium benefit that they got from it. So, there's got to be something in it for people. I think, the banks have figured this out. I don't know if you've seen that, but Capital One has a chain of Pete's coffee houses. They basically give you a coffee house so that they can collect data from you, and you go in and buy your coffee there and have their credit card. So there are creative ways, I think, that organizations can incent patients to get involved, maybe show them how it's going to be convenient for them, or provide better care because someone is actually caring for them and they may feel less anxious.
I kind of think it's also could and should be more of a one-stop shopping where, and some of the portals do have this, where they do have the lab results. So you can schedule an appointment online. You can see how much you owe. Not all of them are. I mean, it's a mixture with different portals. So I think as portals mature and they can see that it's more of a one-stop shopping, that it will be more accessed. So.
I think it has got to do a lot with the health system priority. In the past, my health chart used to be there, but it is not the top priority to communicate with the patient. Now that patient experience is becoming kind of a more important to the leadership team, that the value-based purchasing is in place, that the CMS requires you to do the HCAF survey, and the result of the HCAF survey is tied to your reimbursement, 2% of your reimbursement. Those all tied together. When those all tied together, that kind of give a pressure to the leadership team to make sure that the patients have a better experience in this competitive market. And to do that, I believe the engagement with the patients become a focal point, and then now the latest and the kind of best way to engage with the patient is the mobile digital engagement. And as I told you before, some of the leadership, some of the hospital organization, their educations and kind of opening up account in the my chart is not as optimum as it is in the other industries or other healthcare systems. So it could be because of the infrastructure or the leadership priority, or maybe not enough education and support to the patient.
Thank you. So with that said, how have you guys evaluated the financial and or clinical ROI of these types of strategies? And or if you have not, what would you recommend to healthcare system leaders?
Well, in a value-based care world, for a particular size organization, just missing 5 immunizations might cost you $1 million. So what if you could help those patients understand the importance of those immunizations, and perhaps they come in and do a preventative screening or whatever the right measure is for a value-based care program. So I think that's financially where we're going to start seeing more reasons why giving patients access and communicating with patients, that's going to really drive the ROI on this.
Yeah, I don't think there is a clear formula for an ROI right now. I think there's lots of measures you can put into place and you can look at. You can look at, you know, in our case, for example, have emergency room visits gone down? Have patients showed up for clinic appointments? Are patients coming with their questions to the doctors? Are patients not calling so much after hours? There's a number of different tools that we can put into place and look at with information at our fingertips. I just haven't seen, and I've looked, I haven't seen a real clear-cut formula yet on how to put an ROI around patient engagement. If you have, let me know.
So that made me think about, I often look to other industries for lessons learned that we can apply in our industry. And one non-healthcare term that I think is slowly creeping into healthcare is customer relationship management. And there's a number of industries that have figured this out, and there's a lot of really big, very powerful companies that create systems and tools specifically to provide CRM capabilities. I look at patient engagement to be a similar problem in healthcare of how do we track and manage and best deliver our services to those patients. So with that said, there's this interesting convergence happening with other non-healthcare companies entering healthcare. And I don't have to preach to the choir because I'm sure you guys all know of many of the recent, especially technology companies that have entered the field. Just last week or a couple weeks ago, Google announced that they were acquiring Fitbit is a good example of them slowly making, taking steps into healthcare. And actually, I read that Facebook also bid to buy Fitbit, and they underbid Google by about $10 million. So they almost got Fitbit. So even Facebook, is looking at healthcare and seeing how they can get their toe in the door. So with that said, what are you guys seeing with these? There's a lot of movement with these big companies, non-healthcare companies coming in, partnering with healthcare companies, or just creating their own organizations to take away some of the market share that we talked about earlier today. How do you guys think this will play out? What are you seeing at your organizations or hearing on the ground?
All of Healthwise's technology stack is pretty much in Azure right now. Very secure, private, a lot of great computing ability, and one of the things that we found working with our Southern California HIT colleagues is that a lot of these hospitals have Microsoft data warehouses. Epic Clarity used to run on Oracle. Now it's mostly running on top of SQL Server. And all these enterprise health systems have deals with Microsoft for cognitive computing. And so now Google's coming after that. AWS is coming after it. You've seen Comprehend Medical from AWS. They did this clinical trials work with the Hutch in Seattle to find patients who would be appropriate for various clinical trials. Now they just announced something this morning, Transcribe Medical. So now they're getting into the business that the earlier panel was talking about with Dragon speech recognition. Who's going to win? I mean, Amazon has more employees working on voice computing than all technology companies combined. But Google's been reading your search queries for 2 decades, and they may be much better at figuring out the semantic meaning behind the queries and the utterances where you're seeking information. So they're definitely going to be involved. Apple is going to keep it secure. I mean, each of these companies has a unique value proposition compared to the others. For those of us involved with HIMSS, it's great for us because it's just opening up the playing field a little bit more. The data really will become more interoperable and not just lip service. Like, it really is going to become interoperable. And I believe the power of the patient is one of the ways that we're going to breach those dams and get that data onto their phones in a secure way, and they'll be able to understand it, and they'll be able to go to their care team and say, here's what I need, this is what's important to me. And I'm really hopeful that that technology from these big tech companies will enable the consumer to do things that the traditional health IT companies maybe haven't been so great at doing that.
In using our remote monitoring system and thinking about what might be needed for each of the service lines, so a cardiothoracic patient who uses a remote monitoring system will probably need the sensor bits because they, are more prone to developing atrial fibrillation. They may need the scale, the Bluetooth-enabled scale, the blood pressure cuff. But my colorectal surgery patients probably don't need that. So, I think in developing these systems, we really do want to be thoughtful about how much technology we sort of incorporate in and how many sensors we build into the system, so that it's just not more information and more alerts to the providers, then that's absolutely necessary. So hopefully, with the other players, there will be some more thought placed to development of the technology in a thoughtful way in collaboration with clinicians and care teams.
Well, I have watched a YouTube about artificial intelligence making diagnosis in China. So maybe we're thinking about the Google and Amazon and Apple. Maybe there will be an outsider disruptor, we don't know. The YouTube shows shows the images of kind of I think it's an X-ray or some kind of a CT scan image, whatever it is. So they have the images and teach the machines to make the diagnosis in the images. So the machine kind of read 100 images, make a diagnosis in 10 minutes, the 67% accuracy rate, or maybe higher than that. But doctors, then they call 100 doctors, and they asked to read those images and make a diagnosis. The doctors took much, much longer, and their accuracy rate is much lower than the machine artificial intelligence. So that's one piece of that. So it's not only patient experience, the clinical outcome, making diagnosis, it will disrupt the entire industry, absolutely.
Great, thank you. And we have about 10 minutes left, so I wanted to pause and see if the audience had any questions for our panel.